Welcome, everyone. I'm Michelle Cowles, Director of Business Development with Rogers Behavioral Health, and I will be your moderator for today. Before we get started, I wanted to give a quick overview of the format. The webinar is scheduled for 90 minutes. In order to receive CE credits, you must be logged into the webinar for the entire program. We are recording this webinar and it will be published on our Rogers website along with slides for you to rewatch at your convenience. However, please note that CE credits will not be awarded. Doctors Kramer and Wetterneck will give a 75-minute presentation. Following the presentation, I will facilitate the Q&A session. If you would like to ask our presenters questions during the presentation, please use the Q&A button to send me a message rather than the chat feature. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar. I'll review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. Please note that we have nearly 1,000 people attending this webinar, and we can't get to every question, but we will get to as many as possible and then follow up with you afterwards. Now it's time to introduce our presenters. With me today are the medical and clinical directors of trauma recovery services at Rogers Behavioral Health, Dr. MJ Kramer and Dr. Chad Wetterneck.
Thank you, Michelle, for that introduction. And of course, we have a couple of blurbs here that describe us more. We thought it was important, even if you can see our faces, we wanted to show you what we look like pre-COVID-19 and where we're at right now. And one thing that you might notice about me is that I am in desperate need of a haircut, which is my biggest first world problem. We do have a couple things that we want to cover before we actually get into our material. Some of them are disclosures and overviews of what we hope to cover today. So I need to let you know that neither myself nor Dr. Kramer have any sort of financial interest. So we've each declared that we do not have, nor do our families have, any financial relationship in any amount occurring in the last 12 months with a commercial interest whose products or services are discussed in the presentation. We've also declared that we don't have any relevant non-financial relationships. Additionally, all planners involved do not have any financial relationships. We are hoping that you will learn many things. Some of the specific learning objectives include, when we're done with this, we hope that you'll be able to describe 2 points that offer evidence for the effectiveness of remote delivery of treatment. We hope that you will be able to list at least 2 ways to assess for challenging areas in treatment and treatment delivery. And we hope that you will be able to explain how to formulate and carry out 3 alterations to treatment techniques based on remote delivery of treatment. We will cover more than that, including starting with talking about self-care to clinicians and breaking that down into various areas. Spend some time talking about psychological and physical health assessment. We will discuss what you need to do to try to set up effective treatment, including the beginning, the middle, and maybe the end as well. And then also specifically devote some time to talking about dissociation and how we assess it and also how we try to work with it in our treatment. We also should let you know that want you to be aware that some of our examples, we will try to keep them as de-identified as possible, of course, and also we'll try to make it so that we aren't as triggering as talking about trauma could be. But I think it's fair just to let people know that whenever we're talking about trauma, there is a chance that given the prevalence of trauma, that it may activate something within you, may activate some reactions based on either your personal experiences or working with it professionally. So let's starting with self-care for clinicians. And so during this part, we're going to talk about assessing your own needs during this COVID era, maintaining a support network, and also technology concerns. And I'll just remind you too that if anytime you have questions, please go ahead and use the Q&A feature to send them to the moderator, and we'll try to address them at the end. I want to talk a little bit though about trauma treatment principles, because these are guidelines that both Dr. Kramer and myself recommend. And I think it gives you a little example of how we try to approach treatment with our patients. And we refer to them as patients because we're in a hospital setting. I know many of you will actually talk about them as your clients. So we are looking not only to try to help them in areas that would reduce symptoms and things that they're struggling with, but we really want to also help them identify areas of meaning and values in their life, pointing out resiliency, and also having them be able to shape their life to have the meaning they want it to be, despite the fact that they've encountered one or more traumas. So we'll spend time working on defining and pursuing meaning and values in life. And that means we try to do a lot of different things in treatment, some of them more focused on symptom reduction and addressing trauma and the depression that frequently co-occurs with it. But in our background as well, we're looking at what types of things does the person value? What do they want to pursue? How do they want to define themselves from this point forward? Can we engage them in a sense of self-compassion? Can we work on things that might be helpful for them interpersonally and be able to reconnect, or maybe for the first time connect with things that are intimate to them? And then also introducing mindfulness as well. So we're really trying to help with skills to have them be in touch with their emotions and be able to connect with others in a healthy manner. I think it's helpful as well just to remind people of our pillars of trauma-informed care. There are some modifications that we might suggest that go along with these pillars. We'll talk about them throughout the presentation. But remember that we are trying our best in working with not only identified traumatized populations, but also those that we're not sure if they've experienced trauma, that our main goal is to try to avoid having them feel as though we're re-victimizing them. It's not in the service of trying to help them as well. And I realize some of our treatment techniques involve talking about trauma, so we can't help but talk about it in many of our approaches, but we want to make sure that we are mindful of not re-victimizing them. And that we have to try to view a lot of what we do as, and a lot of what our clients do as, these are likely trauma responses. These are ways in which if they feel activated and they do something that someone might label as unhealthy for them, these are probably ways they learned how to cope with something in the past. And we know that many of our current behaviors that we would label as difficult were once a past coping strategy. So we need to try to remember that and appreciate that even in this new era. And ultimately, we want to try to maximize the choices that our clients have. And that can present with new challenges based on whether or not we can meet with them in person. And as you'll hear, a lot of the stuff that we talk about will have to do with modifications you might have to make when you can't meet with them in person. And then the last two I often talk about together, which is really trying to keep the person's full identity and context in terms of how do they identify with different areas of what makes up who they are in different areas of diversity. And we can strive to be culturally competent, but I really think that our goal should be to continue to learn about cultural competence, because it's a hard thing to ever achieve. I'm not sure anyone could actually be fully culturally competent. In fact, the moment you probably think that you are, it's probably a time to reassess and make sure that you're not making mistakes and assuming too much. And that we're also trying to integrate their identity in terms of how they view themselves as someone that might be a survivor. And they might not use that term. We don't have to use that term, but we need to try to look at their full life experience and cultural background and be sensitive to that. And that means we also have to be aware of how we were raised culturally as well, and what our biases might be. Moving on more specifically to self-care, we've broken it down into 3 areas. One of them will be assessing your needs during this time. Another will be identifying your coping skills and developing and maintaining a support network, and then dealing with technology concerns. So I don't have to remind all of you, but for some of you, if you're newer to trauma, I've hoped you've heard of the idea of vicarious traumatization. And that means that as you are working with someone, you're hearing their story, you're seeing the effects of it, you are being exposed to trauma stories. And in a sense, especially if you're doing something like EMDR or prolonged exposure, you're likely getting a pretty detailed account from your clients that you're working with. This puts you as basically like a spectator to trauma and multiple traumas with the more people that you work with. I also want to let people know that, there may be people that are not therapists that are listening to this presentation. If you are someone that does intakes for your clinic or hospital, if you are someone that does insurance reviews and has to read over notes of people and there are details in those notes, you are also potentially being exposed to elements of trauma. And I want you to let you know this is a normal part of treatment, but that we have to be aware that this is exposure to trauma stories and that you need to do things to try to maintain your safety. So if you're noticing that you have some reactions as being a therapist or exposed to trauma in other ways, just know that's normal, but there are also some steps that we're going to suggest you take to try to make sure it doesn't have long-term effects on you. I also want you to consider whether or not you have feelings of fear, helplessness that resemble the people that you're working with and their trauma histories. I mean, that's sometimes one of the ways we can recognize that you're experiencing some vicarious traumatizations is as you try to conceptualize their cases, and oftentimes you're putting yourself in their shoes while doing that. Do you start to feel the same way they do? This might be a newer experience for you, especially if you have a lot of experience in this field, because you are changing the way, or you may have changed the way you deliver therapy. So does the way you deliver therapy now, if that is even with masks on, with more distance in the room, or the fact that you might be using teletherapy services, does that cause you to rethink things or reevaluate? Does the lack of face-to-face meeting affect you as a clinician? And I think for many of you it will, from the aspect of, do you believe you're providing them with what they need, like with that kind of potential for in-person comfort that is there? And also, do you feel like you're able to notice not only what they say, but all their nonverbal cues that really help you feel connected and be able to better support the client? It's also something I refer to as the new challenge phenomenon. And this happens anytime someone starts a new job. And so we see this all the time. We're training hospital where Dr. Kramer and I work. And when someone starts a new position or when they alter their responsibilities within that position, what we notice is that even someone that was incredibly competent and did an excellent job in one other area, when you ask them to change up their routine, it seems as though adapting and learning new things seems to take more time and energy. It no longer is kind of like a rote behavior. I do it all the time. It's now, oh, I have to think about planning out this session and making sure that I'm ready ahead of time, because maybe the person that's sending the person back to my office, if I'm in a hospital setting or in a clinic, or getting them prepared on the other side, what do I do if they don't show up and I don't see them in a waiting room anymore? So it causes you to have to think more. And I think you should all ask yourself, is meeting these increased needs leading you with less attention and time for other things in your life? So does this occupy more of your mental space? Do you find yourself, instead of knowing you have a full set of clients, thinking about some of the technology changes and some of the other stressors that are coming up? And then also, how are you reacting to your own increased demands or stress that you're experiencing? So it's normal for you to experience more stress, not only because you've had to change what you do during your regular job, but also because you may have some fears and concerns about coming into contact or actually contracting the COVID virus. So I want to first normalize that, but I also want you to be aware of, well, what am I doing in response to this increased demand or increased amount of stress? So part of that is making sure that you're doing good, a lot of self-care and useful self-care. And, you know, there's different types of self-care. And I think I didn't include Maslow's hierarchy of needs here, but I really think we need to start with some of the basics. And a lot of that falls under this area of physical health. Have you noticed whether or not there's been a change in how much you sleep or how much you're actually trying to schedule yourself to have a healthy amount of sleep for you? Are you doing some things that provide you, if it is helpful for you, with a physical relief? Are you making time to eat? Like, this is, you know, a lot of times your schedules are going to be very disruptive, and some of you are probably challenged to get in a healthy or proper meal while working in your job before the COVID era hit us. You're likely to be challenged in this area as well. And then there are many other areas that I'll talk about, including emotional, social, and spiritual areas. But when I talk about self-care, I want you to consider that people look at this on different levels. And I think maybe one of the first levels is finding time for yourself. And then along with that is kind of like doing something relaxing, maybe something fun. A lot of people look at self-care as getting away from work. Like, can I have a divide between work and some of these other activities that I've identified as relaxing and fun? That doesn't necessarily address, though, the feelings that come with you that that creep in, whether they're thoughts or their feelings toward your clients or reactions to your clients, that even if you're trying to have fun and separate yourself from work, those are there. So I think like a higher level of self-care sometimes is processing those feelings regardless of when they come up and devoting some time to it, and not just looking at your self-care as a full escape, because that isn't always possible to do. And I can remind all of you, and you probably know this, that you can't pour from an empty cup. And so that's why we're spending some time talking about taking care of yourself first. Some things that you need to do if I were to highlight some areas, are focus on what you can control. So regardless of the setting, whether you're an independent practitioner, whether you work with a group in a hospital setting, when you think about what you can control, you should be thinking about areas that are about your self-efficacy, and you should be reminding yourself what you're actually doing right. I mean, very likely, most of the therapeutic principles you're following and you did before this era are still correct. And you should acknowledge that. And if helpful, talk to some of your colleagues and reinforce each other for that. But also talk about collective self-efficacy. So I could use our hospital as an example of how we try to focus on, as a team, what are we doing differently among our therapists, among our nursing staff, and other important key roles. What is under our control? So we don't forget about the stuff that we have to try to accept, but while we're talking about problem solving, we also want to try to acknowledge what is still going right, or what is going right despite the changes we have to make. So that's really about acknowledging what you're doing right. And also making sure you're practicing self-compassion. So many of you have heard of either compassion-focused therapy or the self-compassion principles developed by Christine Neff. And I think those are helpful reminders of what compassion and self-compassion are, that we need connectedness with other people. We need to be able to recognize that our feelings and our thoughts, we should normalize that there's more challenges, that this should be more stressful right now, that we're faced with the virus ourselves, but also that we have a change in our schedule, and try to be mindful and also kind toward ourselves. This is also an excellent time to try to review, what are my coping skills? And do I have a support network in place that maps onto the change in how we're leading not only our professional lives, but our personal lives? So everybody needs coping skills. And I love saying this to my clinicians, that all of the skills we've developed and use to help our patients, we all need them and we can all benefit from them. Our patients and our clients, they might just need them a little bit more right now, but this is a good time to remind ourselves, what coping skills was I using? Sometimes I say right before the pandemic hit, but for many of you, I want you to think about, what did you do, whether it was a month ago, a year ago, or a decade or more ago? What did you used to do before you started going to graduate school full time, or committing yourself to like lots of research or studies, or immersing yourself in work? What are those things you did for coping skills? Because sometimes 2 to 6 years of schooling and training, we almost forget those things, and we don't make room for them in our lives. Think about what you've done recently. Think about what you used to do. How many of them are you doing right now? And can you make some time to integrate those into your personal life as well? Everyone needs a support network. And how do we do that when we're trying to maintain social distancing? So some of you right now could think about, I take notes every morning and I write down a list of things I need to do. And I always put a couple things on here. I always have a self-care heading that I put down. And so like, I'm going to take a walk today, and I'm going to talk to one of my colleagues to do a consult, but I know that I'll probably get share a laugh with them as well about just other things that would be healthy for me to do. But before I did this regularly, I thought about, if I had to talk to someone, even if I don't regularly do that right now, who are the people, especially the colleagues that I value and I could reach out to, so that I don't feel distant? And who can I even just reach out to just to say, hey, would you ever have time to do a little consult or chatting with me? So think about, who are your trusted social supports, both professionally and personally. And just know, we can come up with a lot of reasons not to do something that's healthy for us or to make changes. But I'm going to tell you that phone and telemeetings might not feel the same, and you might not view them the same, but they're better than nothing at all. And you will challenge some of your beliefs about their usefulness if you integrate them into your life and you practice them. Okay, last but not least is talking about technology concerns. And I don't have a definitive list about what you can use for various platforms. I'm sure some of you are already at the point where you're using different platforms for different types of teletherapy needs, but you do, consider what you can use with your clients and how do you use it. If you haven't had to make the switch, that's great. And maybe you'll start writing your list of things that you can do and your trusted colleagues right now while I talk about technology concerns. And for those of you that haven't done it yet, many of our interface options for different mediums through the internet are safe and actually HIPAA compliant, and some are not. And some have various levels to them. So I'll use an example of like a basic Skype medium is not fully HIPAA compliant. And I don't know if they fixed this, but part of the reason why is that they own what is written in the chat. So potentially you could use Skype if you weren't using the chat function at all, but yet clients, you know, they might forget, they might use the chat, and then you're potentially violating their rights and having other people have access to confidential information. So make sure that when you're looking at different mediums, you're looking to see whether or not they have something that's HIPAA compliant, medically compliant, and do a little review of that. There are aspects of potentially Zoom, potentially Microsoft Meetings, VC, which is V with an SEE, and I have no financial interest with any of these places, but some of these are mediums that I found that you can use and are HIPAA compliant if you choose the right setting on them. But choose the one that's the right setting with you. If some of them don't allow you to use the chat function, you really think that's important to be able to send them potentially like a link to something you want them to look at. That's a picture or a handout. You know, think about that a little bit ahead of time before you choose something. And then troubleshooting and support. So you can wait to see if you have problems with it, but I think something that's really helpful to do is test these things out with some of your colleagues, or even personally, you could test this out with someone that is willing to talk with you. And this could be maybe the first time you actually connect with a colleague. And the reason could be, you know, 2 birds, 1 stone here, that we are trying to practice using a different technology, but it's also another way to connect to someone else. I would have a plan to explain technological solutions up front with clients. That doesn't mean you have to have all the answers, but I do think that it would be helpful if you said, if we get disconnected, here's the protocol that I will have in place. I will send you something through a chat window, or you have to determine what your clinic or hospital or your own personal preferences are on how they can contact you, whether it's through a Google Voice number or it's through a cell phone that's designated to a business practice. That's without your own preference level on how you want them to contact you. But I would tell them that ahead of time, because it'll reduce your worry and it'll provide them with some safety and positive thoughts if you do get disconnected. So we're going to move on and talk about psychological and physical health assessment. Before we do that, I just want to check in with my co-presenter, Dr. Kramer. I said that I'll be pausing after some of my bullet points and slides. Is there anything you wanted to add to some of the self-care aspects that I was discussing? And you might be muted now, so make sure you...
I'm going to get into some of those points during my discussion later.
Okay, great. Okay. So under our psychological and physical health assessment and recommendations, we'll spend a little time talking about some of the interviews and measures that we use in the collecting the information, and also some of the medical aspects that we would want you to be aware of, anticipated issues, things that might help you in the meantime, and also just updates from the CDC and other areas. So in terms of interviews and measures to use for collecting information, I'm going to talk about those in a couple of different parts here. And one of them is incorporating assessments and measures to assist with determining suitability for treatment. So a lot of what we're talking about here, as you're recognizing, has to do with some assumptions that your current work has changed to some degree, that you are either not able to come in contact with clients, or if you're an administrator or a supervisor of others or a program, that you might have to have distance with the people that you're working with and supervising, or all the way to some of you might be operating full teletherapy and full telecommunications with anyone that you have to work with, whether it be peers, colleagues, or your clients. So we want to talk a little bit about the use of assessments, and also pay a little bit more attention to dissociation, which we will talk about toward the end of the training as well. One of these is just talking about the basic idea that we want to encourage you to use assessments. You know, if you're going to change a little bit about what you do in your practice right now, and you haven't been someone that liked to give kind of like weekly, bi-weekly, or maybe a monthly assessment, consider doing that right now, because I think it'll help you in a couple of ways. It's a new thing to learn, so that might be the con of adding an assessment to your practice. But the pro might be that you're getting some standardized, concrete information that you can start using and developing your own measuring stick with, usually with actual numbers. If you familiarize yourself with some measures that can capture some of the symptoms that they have, and that can lead to another way to try to track progress. And it might help fill some of the void that you're getting that you used to have with just like kind of like the connection you had in the room, and noticing their nonverbals. And also, I think you need to spend a little bit more time talking about dissociation in either a screening, and that adding some sort of assessment measure would be useful for that. So things that we might, and also looking at the area of technology and video, which I'll go into in just a little bit. We want you to think about journaling and self-monitoring also as a form of assessment. Many of you may do this already, but if you don't do this already, it would be helpful early on in treatment. Most of you are probably thinking, if I accept a client, I'm going to keep them. But I will often tell patients that come into the hospital, or even if I was doing any outpatient work, my goal in the first couple sessions is to make sure that I'm a good match for you, or our program is a good match for you. And so part of that is, the more information I have early on, the sooner we can decide that. So journaling and self-monitoring, what would we journal about? It would be some of their emotional experiences. It would be about some of their dissociation, and I'll talk more about that in the upcoming slides. So in terms of appropriateness for treatment, we have to consider things about whether or not only some of the client variables, but also some of their environmental surroundings make them suitable for doing teletherapy if that's the medium you're going to have to use. So we need to look at early on, where is their location? And I don't just mean like where in a city or rural or suburbs. I mean like, what is their surroundings like in the room that they're going to use? What are some of the safety variables we have? So some of the basic ones we might use, for example, are they living with someone that is a current or past abuser, or someone that has been participating in their trauma in a negative way? That's something that we would assess from the beginning anyway. But is that someone that lives close by or keeps tabs on them, stops by the house? Because this changes the level of safety they might feel in their environment and changes how much we might be able to engage with them during this time. Also trying to look at the presence and severity of dissociation. So of course there's clinical questions you can ask people about dissociation, and it really helps to have and to look at some psychoeducational material on dissociation if you don't already have that. There's lots of work done by Judith Herman and others that I would recommend. But if you're looking for something that's more of a measure, I would consider as a short measure, something like the Dissociative Experiences Scale, second version. So the DES-2 is something that is a free and open measure, and it's pretty easy to understand questions, and it actually has a little scoring guide as well that says, if someone is more likely than not maybe to have PTSD or some dissociative experiences or potentially even a dissociative disorder. You should not use this for diagnosis, but the higher they score on this measure typically means they're going to have more difficulties with dissociation while doing the work. I will let you know from our own professional experience and our use of that in the hospital for at least a period of time that what I found is that this particular measure is unlikely to have very many false negatives, which is good because that means it's identifying people that are likely to have it. But I did find that it has a fair amount of false positives, meaning a lot of people could score high on it that actually don't have any dissociative concerns. But when we're talking about statistical error or some other error things, we'd rather know that someone has a potential for dissociation and then find that out over time and treat it as they might have dissociation concerns than not. Something that I would recommend is a potential follow-up. It's kind of long, but you should be able to find it on the internet and for free, is something that's called the Multidimensional Instrument for Dissociation. And that's something that's developed by Dr. Paul Feld, and it's free to use online. It's kind of a long measure, like the DES-2 is only maybe 30 items or so. The MID is actually something that's closer to 300 items. So I'm not recommending you give this to all of your patients, but if someone scores high on the DES, I would consider having you look at this measure because it is standardized and normed. It has its own built-in validity scales. It's free to use. It gives an interpretation guideline and actually a guideline that you can look at to tell you how to administer the test as well. But if you expect there to be some dissociation concerns, please consider looking into that measure as well. With dissociation in general, we're looking for basic questions you can ask about are how often does it happen? Severity, now the client's not going to know what severe means. And so sometimes that's going to be determined based on how long do these things last for? So what's the duration? How connected do they feel to their actual environment compared to whether it almost feels as though they're in a full flashback and they're not maintaining any sense of their current reality to them. Like their brain is really telling them, no, you're in the trauma situation right now. And then also another variable that we would look at in severity is whether or not they could be prompted or use a grounding technique to try to have them connect more with what the current actual surroundings are with them. Now, knowing these things early on might determine suitability or where to start in treatment. So if you feel as though you can learn more about how to properly ground someone and when to do that, then I would suggest that you consider still working with them, but maybe what you're going to need to do is focus and emphasize more on the grounding work rather than getting into some more active treatment components. I mean, these are all active treatment components, but the ones that might actually challenge whether you're doing EMDR or whether you're doing something like prolonged exposure and asking them to talk about some of the traumas, those are things that you might hold off on until you've successfully taught them how to do grounding procedures. But it might determine, if you don't feel comfortable or you don't feel like you have adequate training in or supervision that could help you lead you through these dissociations that the client could be experiencing, you could consider a higher level of care as well. Now that could be you meet with the patient more often, or it could be, if you have that option, you look around for IOP or partial programs, or even decide, hey, this person might not be able to do the work early on or later on. Maybe they need something like a residential program. Anyway, there's things to consider early on, but it's nice if you let the patient know that you're going to work with them for as long as you feel like you can be effective and the therapy can be helpful. But I know it can impair with a little bit of the rapport building, but to let them know you're going to do what's in their best interest, which could mean, it could mean a different level of care or a specialist in someone who does dissociation work. Now we'll move on and have Dr. Kramer talk about medical considerations.
Thank you, Dr. Wetterneck. So before I get into medical considerations, I do want to review 3 unique concerns to the PTSD population, and these are going to be present regardless of level of care. So you may notice this, an outpatient, intensive outpatient, partial hospitalization patients as well. And it's really centered around the need for social distancing and the universal masking requirements that have occurred in the general population. And that's just serving to activate some core schemas. So, for instance, the world is an unsafe place is a very common schema among the PTSD population. And again, with the COVID restrictions, that schema is really going to be activated. In addition, symptoms of panic. So when someone's having a panic attack, one of those symptoms can be shortness of breath. And that is similar to that key COVID-19 symptom. So that can also be a concern. And then lastly, the DSM-5 criteria of isolation and avoidance for PTSD. Again, I think that's only intensified by these social distancing requirements. So when looking at medical considerations and referrals, PTSD has a lot of comorbidities. So that includes everything from personality pathologies to eating disorders, obsessive compulsive disorder, but also substance abuse is very comorbid. And during this isolation during COVID-19, it really has led to a marked increase in substance use. So many clients who may have been able to maintain sobriety are now reporting relapse. So, a need for a careful update and maybe a new screening if necessary, just to ensure that, that substance piece is being addressed. The other concern there is the AA-NA meetings, which are usually in person. That availability is now very limited, again, due to the need for social distancing. So that too can increase the risk for relapse. I know on our residential unit, we're utilizing addiction counselors quite frequently, and it can fill in those gaps. But there may need to be some more creative solutions on the horizon to help those individuals, especially if they're in early recovery. Next slide. So to revisit the social distancing piece, if you look back in history and examine the fallout of other pandemics, and also looking at large-scale disasters, whether it's Zika, SARS, mass shootings, hurricanes, these events will invariably lead to higher levels of PTSD as well as depression. So being aware of this and screening patients for PTSD more diligently during this pandemic, and also screening for an increase in depressive symptoms is paramount. Equally important is the need to re-examine level of care. So patients who may have initially been appropriate, as Dr. Wetterneck mentioned, for outpatient care, may at this point, due to an increase in symptoms, need a higher level of care, whether that's a recommendation for intensive outpatient or even a partial hospitalization, perhaps even a recommendation for residential, because the need to manage the severity of symptoms, which can increase markedly while dealing with the pandemic. Next slide. So another concern is that non-essential medical, surgical, and dental procedures are being eliminated, really for two reasons. The demand for healthcare workers is being shifted. And so they're managing the COVID crisis. And then ECT being the exception, it's still considered an essential procedure. But then also, if you think about it, there's an increase in the risk for contracting COVID for a non-essential procedure, especially if it's being performed in a surgical center or a hospital. And so this is not a risk that most people are willing to take. And so this in turn is leading to a delay in getting treatments for those conditions, many of which are now being managed by psychiatrists and mid-level providers, especially in the residential setting. Next slide. And to revisit universal masking, this is something that we've incorporated on our residential as well as our inpatient units. And again, it's become a significant issue for those with trauma. Especially vulnerable are individuals who have a traumatic event that would involve being gagged, or the perpetrator covering the patient's mouth during the traumatic event. So this can be a huge trigger. We use a 1 to 7 anxiety scale. This would be a 7 for most individuals if the trauma did involve being gagged or physically silenced. So that can easily precipitate a dissociation or a flashback. So as such, these individuals may need assistance from the therapist in masking trials to acclimate, because wearing masks, whenever you go to the grocery stores, and whenever you go to the pharmacy, really, it's going to be a requirement, and it's going to be something that's going to be a new normal that we're going to have to adjust to. So considering the fact that some of your clients may need to sit in the office with you and practice wearing the mask. And then in addition to that, I have noticed that not only in my practice, but in several of my colleagues' practice, we are incorporating more liberal use of PRNs, or as needed anxiety medications, just to help abate the increase in anxiety during this transitional period. Next slide. Not as significant of an issue, but something to keep in mind is that supply line issues due to medications being manufactured overseas in China and other locations can lead to prescription shortages. And so this is an issue, and it's just confounded by the fact that a lot of patients are stockpiling medications as well. So the FDA, although they do have measures in place to mitigate drug shortages, currently that list of medications that are in short supply, it continues to grow. So some of the psychostimulants are on that list. Some of the non-addictive anti-anxiety medications are also on the list. And some key antidepressants are actually running in short supply. So the medical provider and the psychiatrist may need to consider alternatives during this time. And in doing so, if a client is stable on that medication, it may lead to a decompensation if a change is implemented. So just being aware of that, maybe asking your clients, hey, are there medication changes that have occurred due to this pandemic, and keeping that in the back of your mind whenever you're treating clients. Dr. Wetterneck, you're muted.
Thank you. Thanks for all that information. And, you know, during this next part, when we talk about effective treatment, I know Dr. Kramer will add probably other pieces too, because one of the changes we've had to make is we've had to have some of our staff operate remotely in order to make sure that we have tested things out and can pilot what's needed and to ensure kind of high levels of safety in our organization. So in this next section, we'll talk about implementing effective treatment. We'll hope to provide some examples and share some de-identified examples of special modifications we'd have to make. But first, we'll start with a review of remote therapy approaches for trauma and PTSD. Then we'll get into that altering context and any other alterations needed to treatment. And finally, we'll talk about measuring progress a little bit more. So the good news is there's a lot of work being done to try to do what we refer to as remote treatment. There's a variety of different types of remote treatments that have been studied. At this moment, there's actually either dozens of randomized clinical trials, case studies, case series, and other types of peer-reviewed writings on the effectiveness of doing trauma or PTSD work. So that's really good news. And I've referenced a few of the studies that have actually aggregated some of the results from different areas, from civilian populations and outpatient treatment centers, and also those that are being operated out of the VAs as well. And what we're seeing here by and large is that teletherapy, whether it's done over video, over phone, and there might be a couple of other modalities that get integrated into those two, it has been effective. And we need to know that as clinicians, because in working with anxiety disorders, obviously we're going to share only factual information with all of our people. But it's also something that we need to be able to convey to the people that we work with. So we need to be able to let them know that we're not doing this as the next best thing. We're actually doing this because it's been studied, and it's been found that, for one thing, treatment outcomes are similar. And there have been some studies that have actually shown, mainly it's equivalent, but there have been some that have shown actually slightly better outcomes, not significant, but better in some of the teletherapy approaches that have been used when compared to in-person sessions. Some of that could be due to the fact that while treatment dropout is generally equivalent, there might be greater adherence for people that appear in person, and that could have something to do with their level of investment and making potentially extra sacrifices to commute to an appointment and do other things. But that there does seem to be some capture of more folks that maybe they weren't as sure about wanting to go to treatment, willing to see treatment through when it was done through teletherapy methods. So that's kind of an interesting finding, that the more data we get on this, the more it might be maybe some people, similar to how we try to approach some of our addiction treatment, maybe some of them need and are ready for, in the stages of change language, they're past pre-contemplation and contemplation, and they're ready to go into active treatment. And maybe they're going to benefit either way from in-person or more teletherapy methods. But the folks that might be a little bit more pre-contemplative or contemplative, of course, they're probably at least contemplative if they're calling a therapist. Maybe those are the folks that are the ones that they could use teletherapy and are more likely to benefit, because it hasn't caused them to, change their whole life to try to make a weekly appointment. There's no differences in treatment acceptability. So a number of these studies asked patients to rate on standardized forms. Do you think this treatment is appropriate for you? Would you recommend it to others? Would you do it again if you have the same types of issues? And we've seen that there's no differences in our randomized controlled trials on this. We've also seen, and I think this would be of great concern for many of us here, because a lot of us say that we have a feel for the patient based on being able to be in the same room with them and seeing their whole body and taking in all of their nonverbals. And of course, you know, if you've done telework, whether it's professionally or you've talked to people on different mediums and Skype, you know that it takes time to, I feel like I'm looking right at my screen right now, but if I want to look at the camera, I actually have to look at the little dot, and then I won't be able to see any of my notes. So you have to make some adjustments there. And you might think that that might compromise the therapeutic alliance. So I think one thing that you can do is you can let your clients know that it could take them a while to habituate to that idea that the therapist might not be looking like they're looking directly at them. But I might actually say, this is when I'm looking directly at you in the screen. So if you notice how my face looks right now, even though it doesn't look like I'm looking directly at you, you can know I am looking at you. But the good news is that treatment alliance has been acceptable for either, meaning like a minimum criteria. And of course, we're never shooting for minimums, but in-person and tele showed that people can develop healthy therapeutic alliances. And there was only a slight favoritism in-person sessions over outpatient sessions. I'm sure there are many individual variables that would play a role in here, but I'd like to tell that to patients early on because they might think that as well. I won't get the same feel for you. And I just ask them to commit. Can you commit to X amount of sessions first? And can we reinvestigate this and keep it open as a point of conversation? Many therapists, regardless of whether they're treating trauma or something else, are concerned about whether or not their clients could be suicidal and what level of suicidality they have. And so this was actually through interviews of various therapists that did some of these treatment trials. They asked them how concerned they were, and sure enough, they were just as concerned or more concerned during doing teletherapy with someone and saying, how am I gonna manage this? I'm like literally not in the room with them. And you know, you do all of the things you normally do, which is you have them have, you know, a plan when they have their urges are high. What would they do, whether you're there or you're not there? What will you do, and let them know? What will you do if in a session they have high suicidal ideation and you don't feel like they are able or they're not willing to engage in any of their coping skills? But one thing that was reported at the end of these studies, in addition to utilizing those same types of approaches to managing suicidality, is that the therapists using the telemodalities did not report any increase or any differences in how much suicidality or suicidal concerns they had to manage. So the patients then weren't experiencing it any more than they would normally in person, and the therapist didn't perceive that it was more of an issue. And then there's this idea of therapist fidelity, meaning are they doing what they're supposed to be doing? So you know, in some of the more randomized clinical trials, they're given a manual and they're told, hey, can you adhere to this manual, you know, to a high level so that you're getting across the basic concepts? And of course, in most of our outpatient work, you could adhere to a manual, but you might have internalized whatever manual or however you learn to do this treatment and be more fluid about it. But in our more tightly controlled studies, we've found that even in the teletherapy methods, therapist fidelity seems to be just as high, and they appear just as competent to someone reviewing sessions as the people that are doing the sessions remote. So they're not afraid of, they're not getting distracted or checking their email or doing other things that get in the way of administering therapy. And then the last point that I'd say that you need to know and you can share with some of your patients if you want is, this is a treatment that has a lot of research evidence where there's a lot of diverse testing being done. So there's a couple of studies that have come out, and I think one of them might be referenced in the guide here. You know, a lot of the studies that have been tested for teletherapy, and I realize there are many different therapeutic approaches and many that do a wonderful job treating trauma and PTSD. One of those is prolonged exposure, and that happens to be one of the treatments that probably has the most diverse populations included in the randomized clinical trials when we look at more of those tightly controlled studies. So a lot of this efficacy we're seeing here and lack of differences in outcomes with in-person versus tele methods are found from prolonged exposure and other validated treatments. So there are some modifications we're going to recommend and specific, maybe even case things that we'll talk about when it comes to looking at the context and alterations to treatment. And I know Dr. Kramer mentioned one of them already, and she has other examples as well. One of them is finding a safe place for the client. So you have to keep in mind that for some people, regardless of their age, they might be in the same house as where the trauma took place or the same neighborhood. And so this challenges us to provide that same level of safety. They might be around people, even if they're not a current abuser, that don't understand what the client is going through. They might be someone that's frustrated and actually kind of punitive with them, that they're not able to manage their symptoms differently or better. And so we have to ask ourselves, is the current context or method of connection a trigger for the patient? And what concerns do they have? And one more I'll add in there as well before I check in with Dr. Kramer on some of her thoughts is she mentioned that some people were prevented from screaming. Their mouth was covered. And now this is what we're asking them to do. In our setting, we may have to ask them to wear a mask for COVID restrictions. If you haven't worn a mask yet, think about, well, try it if you can, whether it's cloth or a surgical mask. And you will see, you'll notice sensations around your face. You'll notice your breath coming out. You'll notice that people can't see the way you look, so you're probably not communicating. I do a lot of nonverbal smiling. Those are my hellos. Well, you might not know it unless I pull my mask down. And our patients may have had something, and this won't be all of them, but for some of them, their trauma was recorded. They were physically or sexually assaulted and someone got cell phone video of it, or was used for other nefarious means, and they know that that happened. Or they might know that their pictures or videos are out there of them. Maybe it was someone bragging about a physical assault. And so think about what happens when you're asking them, can you participate in a live video stream? Maybe even using some of those same words could be triggering for them. And you're not only going to see yourself, but you're going to see the therapist. And so another thing I'll bring up is having to see themselves on the screen. That might be triggering for them in terms of how they view themselves and whether they feel like they're worthy and whether that's a trigger. And if they look like they're scared, does that augment their fear response when they see themselves afraid while talking about these things? Dr. Kramer, are there other things that you've noticed that we need to do in this area?
Yes, actually. So I can tell you I've been doing telehealth with all of my patients for the better part of a month. And so, I treat the spectrum of PTSD. So residential, I follow them when they step down to the partial hospital level, and also intensive outpatient. And when they get to partial and IOP, invariably, there are some concerns about the telehealth piece that we didn't have to address in residential. And one of the big concerns is privacy. So, a lot of our clients live at home, and now the children are at home because everyone is doing school remotely as well. So it is a question of I'm going to do my trauma narrative with my therapist, or we're going to be talking about course schemas, reviewing some really personal information, and the patient is invariably concerned, what if my young son hears me? What if my daughter can overhear what we're discussing? That could be traumatizing for them as well. So one solution is a solution that we've used very effectively in the partial program, and that's sound machines. So in partial, all of our rooms are back to back. They're very close, they share walls, but plugging a sound machine in and setting it not in the room, but outside the door is a very effective means of increasing that privacy. And so I've made that recommendation with good benefit. It provides an opportunity for the patient to feel like they don't need to hold back, and that they can share without the fear of someone overhearing the intimate details of a conversation between them and their therapist.
That's an excellent point, and something that is generally fairly cost effective for our clients. And I don't know if those are in a shortage right now, so hopefully something that they can get. Another thing I want to talk about is pros and cons of their actual home environment. So we just brought up a number of things that could be challenges that we maybe hadn't thought of, or that we have to try to address in therapy. Let's think about some of the things that might be additions to therapy that we could do as well. And remember back to what I said about self-care. We want you to try to focus on, well, what is going right? And whether it's your individual work or as an organization, what have you successfully been able to change and manage? And you want to bring that into your work with the client as well. And that doesn't mean you tell them all the good stuff that you're doing, unless it applies. It would more mean, is there some advantages to actually being able to connect with them? And can you help point that out to them that, you can understand them potentially better by being able to see part of what they see every day. And that's not something that you typically get to do. And you can help choose if they had, for example, more than one room they could use. There could be a room, they could pick a room because they think they're supposed to have it or that's the only one available, but you could let them know, well, if there's a room where you feel as though either it would make you feel more safe and more open and is more protected from anyone else that might be around to use that room, or you could also bring up the idea that if they already have a safe place, maybe they don't want to talk about their trauma there quite yet. Maybe they want to designate a separate room so that they still have a place to go back for safety when they're done with their session. And when they want them to have them apply some more of their coping skills and grounding. Of course, it could be helpful to teach them in their safe place how to do that grounding appropriately. So there is no one right way to do this, but you have more options, and it's nice to be able to tell them that you have more options. I also feel like you might be able to do some of these things that you're asking them to do in their home environment. You might be able to walk them through that during the session. So in our line of work, we do exposure work. And when we say in vivo, it means the client is doing something that makes them feel like there's a trauma trigger present, and they eventually habituate to that. So you could be there to assist them with something that could be an in vivo exposure. And it could be something that maybe they couldn't have done on their own, but the fact that you're there and present with them through the methodologies, that could give them enough comfort and safety to be willing to challenge that and actually reduce a trigger that could be in the house. Could also mean that you shape some of their environment as well, which I'm going to get to on the next slide. So I mentioned that it would be helpful to add some standardized measures. And then I really only talked about a couple that have to do with dissociation, but I want to take a minute or two to talk about some other measures you might consider. Now, these are not the only measures that you could use, but all the measures that I'm going to recommend, if you feel like could enhance your treatment approach overall, it might give you an extra way to connect with people during your social distancing practices, and they're all free and open to the public. And have been validated. So, for example, if you haven't worked a lot with trauma and you want some guidelines on how would I do an interview with someone to really get some information about their trauma symptoms, there's something called the Clinician Administered PTSD Scale that the Department of Defense has developed and keeps revising every time the DSM comes out. So the acronym for the Clinician Administered PTSD Scale 5 is the CAPS-5. And that basically tells you exactly what to say. It gives you rating scales and allows you to develop your own measuring stick for how certain symptoms, how severe they might be, by giving you anchor points and ways to measure this. And it's a really great thing to use early on in treatment if you don't have another standardized approach to asking people about their trauma. And I think people get a little bit of comfort. I know sometimes people say, well, maybe I don't want to talk about trauma right away and I want to introduce them with grounding techniques. But there's something about sometimes introducing material, like here's an article to read or a book. And here's an interview that's designed by the Department of Defense for anyone that has had trauma experience. And it guides people through the experience. That feels like it gives some sense of certainty and sometimes some safety to people that you have to ask these questions to. I'll mention a couple of measures that look at symptoms. So The Department of Defense also has developed the PTSD civilian and military checklists. So those are two separate checklists. One asks specifically about trauma symptoms, but uses language that's more friendly to folks that have been in the military. And then the other asks symptoms that is devoid of any military language, asks about the same symptoms you'll find in DSM-5, and gives clients a rating scale that will map onto criterion B, E, C, and D. And these are excellent measures to use and have been used in multiple randomized clinical studies and lots of outpatient work to try to track progress and change across sessions. There's another that's called the Post-Traumatic Cognitions Inventory, also free and open to the public. This one looks at 3 main areas of common trauma beliefs that develop after trauma is experienced, and focuses on areas such as the person's sense of blame and responsibility for what happened. And I think Dr. Kramer mentioned some of these schemas already that pop up for them, that it's their fault, or that the world is a dangerous place, and things are more likely to happen that have already happened in my past. And then the last area it covers whether or not they can trust themselves and other people. So their own emotional responses, or if people can be trustworthy. So having a snapshot of how highly people are concerned about these different levels of beliefs that probably develop from their traumas, it's really helpful information, whether you're doing some sort of thought challenging with cognitive therapy, whether you're doing the processing work after imaginal exposures and prolonged exposure, whether you're just talking with them, whether you're using EMDR or another modality to understand how highly they endorse certain beliefs ahead of time can be really useful. And then of course, there are things you can use, measures for depression, the BDI first edition, which correlates about 0.95 with the one that you have to pay for, which is BDI 2, that's open. The quick inventory for depressive symptoms short form. These are measures that are 16 to 20 items long and open to the public. But I really feel like if you start using some of these measures now, you might get used to them and you might find them as another useful way to help the client see not only when are they getting better as a result of treatment, but also when haven't they made changes, or when don't they endorse the changes even though you're seeing them, so that you can prompt them to either recognize more changes, or you can give them feedback like it might be time to try something different, whether it's with you as a clinician or a different level of care. So I mentioned that I would talk about changing the client setting to enhance the therapeutic experience. One of those to make them more comfortable and more safe is the example of that sound machine. But another is getting an idea of what the client can see when they're talking to you. If they had a laptop or a handheld device, they could show you what do they look at, what's in their surroundings in their room. And can we change that over time if it's not something that can help them be connected and grounded? So some of our clients might report, well, I think someone might come in, or I'm worried about someone trying to make a delivery at the front door, and if it's someone that's actually a bad person. So I'm set up in a room that I can see the front door and I'm looking outside while we're talking. Basically, I'm trying to monitor threats and I'm trying to protect myself, but it's really actively engaging in some level of hypervigilance. And we are not asking them to remove all levels of safety right away, but we want to be aware of that so over time we can get them to try to practice doing things that will also help them attenuate things that help them recognize that they could be safe in this moment right now too. And what could that be? It could be things that they already recognize could make them safe. It could be music. It could be pictures. It could be pictures of family members that are safe to them. It could be things that they draw or do artwork wise and that they actually then hang up in their areas, whether they're safe areas or their treatment area where they're actually doing their teletherapy sessions. So lots of options open up once we get to see what's around them. And just want to check in if there's anything else that you wanted to add, Dr. Kramer, about changing settings. Otherwise, we'll go on to dissociation.
Yeah, just to add, obviously not everyone needs to buy a noise machine. You can, Alexa, if you say, Alexa, play white noise, that's an option. There are apps on phones that can do it. And just to echo Dr. Wetterneck's observation, I do see clients in partial and the room was dark. And I realized they had pulled the blinds. And so we discussed the rationale behind that. And it was due to, an increase in suspiciousness and hypervigilance outside of the residential setting. So it was something that we were able to address that otherwise I wouldn't have been aware of if not utilizing telehealth. So there are some benefits there.
Okay, well, let's move on to talk about dissociation. And I know that many of you are already submitting questions. I appreciate that. And just a reminder for those of you that you have that option to use that Q&A feature. And we are trying to shoot for about 13 to 15 minutes of questions. So let's continue on with the presentation. Revisiting assessments and a few other areas that we want to talk about. So it would be helpful if you do incorporate any sort of dissociation measures, especially if you do what I refer to as the Dissociative Experiences Scale 2. I refer to that as more of a screener. So you might have your own interview questions, but if someone scores high on this measure, and again, if you download this measure, if you just Google, Bing, or Yahoo it or whatever, you will find that it comes with the scoring guide. If they score high on it, this is a sign that you need to walk through the questions with them that they endorsed as higher than others. It's typically like a 1 to 10 item measure, and anything that's a 4 or more, I'll ask them about what they mean, because sometimes the measure will ask about, I find myself daydreaming when I'm reading. Well, maybe they're just caught up in a good book, and you need to know, is this actually dissociation related to trauma, or is it really they're kind of sucked into a good book, and we shouldn't really think about this as a high score in that area. You should also review their dissociation log with them, and this would look at various aspects that are more behavioral and measurable. So at minimum, how often are these dissociative experiences happening? So maybe by the third session, you might have a week or two of this as actual data to review. And it might map onto what they endorsed in your clinical interview or in the dissociative experiences scale, where you might find that it's different. And then when there is a difference, which data do we trust? So let's continue to collect some data on it. Maybe we'll re-administer that measure in between sessions to help clarify now that we've given them more of an idea of what dissociation is. And then we might do something if we suspect that there is dissociation present. That is a pretty tried and true dialectical behavior therapy recommendation, and that is do a behavior chain analysis. So if you've never done one of these before, if this is a new term for you, the good thing is you can look this up online, and you can find often some free resources that will likely be able to walk you through this enough where you could decide, do you want to implement this in your own practice? And what we're generally doing in a behavioral chain analysis is we're trying to ask them about a very specific thing that occurs for them, whether it be a behavior, a thought, it could be actually an emotional experience, it could be the experience of dissociation. And what we're asking them to do is, can they trace back what happened before this? And they might go back seconds, minutes, if needed, hours or days. And we ask them to think about different situational factors, different experiences they had, whether it be emotional or thoughts that they had, interactions with other people. And this allows us to try to see what happened before someone actually experienced a dissociative episode of some sort. Can we start identifying different things that might be warning signs or triggers that make it more likely for it to happen? Because ultimately that's going to help you determine, where are my interventions going to take place when it comes to dissociation? So I'm going to tell you some things that you might want to try when they're actually experiencing some dissociation. But I find that a really thorough assessment allows us to try to have intervention before dissociation occurs. And part of this comes with making our clients more aware of these signs that dissociation is more likely than not to occur, and having them take some steps to either introduce grounding or just increase their awareness so that they're more in tune with that it's coming on. And sometimes you'll have clients that say, it just happens. It's like I snap my fingers. And for some people, it is like that. A lot of those folks, though, when you have them do this behavioral chain analysis with multiple situations, they say, I guess I'm starting to notice sometimes before actually the snap happens and before I'm fully dissociated. Very useful. So one thing that you're going to want to have on hand is psychoeducation about dissociation, first of all, and what that is, but also then psychoeducation about what do we do in response to this. Again, I think this would be really helpful if you have forms and things that, they come from good blogs sometimes that our therapists are writing. Sometimes they come from books that you can get access to. Judith Herman's work, some of Ruth Lanius's work on, how the brain functions and what leads to dissociative episodes. Some of these books contain worksheets. There are entire organizations devoted to studying dissociation. And I believe Bethany Bland did a APA seminar not too long ago talking about dissociation as well. Some of these are recommendations that I noticed were part of her seminar and I thought were really helpful. But being able to provide that as psychoeducation for the client or patient in order for them to be able to see, yeah, we've developed materials on this. I think it develops a higher level of comfort that people study this and people are really have a beat on how to do this. So we need to teach them what grounding is. And that's really about trying to have them stay mindful and in contact with the present moment. When should they use it? They don't have to use it all of the time. They have to use it when they feel as though these dissociative experiences are starting to have them lose more connection with reality and they're getting to a point of where they might not be able to stop it. And so when we do exposure work, what we more specifically say to them is, if you're willing to tolerate the current level of distress, you may do so. And you could still have some dissociative experiences, but you'll learn fairly quickly when those dissociative experiences might overcome your ability to stay connected, even with the emotion we want you to stay connected to. And we need to identify some fine line between, I have some dissociative experiences and I'm about to tip over into a more dissociative experiences and not being able to stay in contact with my present emotions. If they're willing to tolerate it, you don't have to try to ground yourself, but you should be aware and be ready to ground yourself if needed. And then of course, there's the how do you stay present and why do we use it? For some people, we have to explain just using grounding skills are helpful because what is dissociation? Well, many of us conceptualize it like, this is your protection skill. Now, some people look at that as it means I am like an extra level of there's something wrong with me, or they say I'm extra crazy because I lose contact with reality. Of course, we don't see it that way. It's part of your trauma response. We need to normalize this. And that's some of the work we need to do when it comes to dissociation, is normalizing that as a natural response. And then there are others that say, but I want to not feel these things. And if you're using many of the treatment modalities that require having to teach them to tolerate some level of discomfort so that it's not an issue with any other type of discomfort causing you to think you have to ground yourself all the time. We need to teach them, you should try to ground yourself because it would keep you in touch with what we're trying to teach you, but also if you only escape from the trauma in this method, you might not learn ways to be able to cope in all types of situations that you might want to engage in later in life. So it's not that we just try to convince them. We're going to do a pro and cons journal with them. And we really want to try to meet them where they're at and emphasize that grounding skills are important, and their dissociative experiences, if they were okay with having them, we understand that. We want to validate those as well. We need to do that before we can try to convince them that their methods are needed. Now, I know we're getting right up to the time where we're supposed to do questions, but I'd really be beside myself if I didn't include a couple of things here about cultural awareness and other supports. So very, very briefly here, I know I only have one slide on it. We have to try to consider and looking at our clients very holistically. They're not just someone that was traumatized. We're not just treating them as a trauma survivor. They have many strengths that they might be able to rely on, or things that are available to them that we could foster into strengths. We have to try to see them as a full person because they may have already thought of themselves as someone that's broken and traumatized, and broken because they've been traumatized. So we need to focus on identifying strengths. And a lot of that might be found in some of their areas of cultural supports that they have or that they could have if we could introduce them to them. So this is a reminder that we need to explore more about a person's individual culture, be aware of our own cultural experiences and biases. And our goal is to try to understand what is functional and what is not functional in the context of their culture. So for many people, especially people of color, to be able to talk about how in this current environment that they might be more marginalized than other people when it comes to getting access to health care, that they might have more essential worker jobs, or for some, they're going to view it as I'm more likely to be laid off and lose my income because of other cultural factors. We have to be able to meet them where they're at and validate that and be able to share data that's likely supports that that's what's happening, and that they will find comfort not only talking to us, but also making sure they're staying connected to communities that they find supportive, whether they define it as based on being other peoples of color or spiritual and religious views or other things that could be supports to them. And I think a lot of you already know that it's important to involve supportive family members in treatment work. And if they're not supportive, that at minimum, we can get them into a session and we talk to them one-on-one, that perhaps we could educate them about what PTSD is and why there's difficulties in trying to connect with some of their loved ones, that would be very useful work. But that's all I'll say about those latter bullet points on that slide. And then just remind you that we want you to be aware of your own self-care needs as you're trying to help others. You have to likely make some alterations and assessments. Treatment can work. We have data on this. So there's hope here, and we need to focus on that hope, not only for yourselves, but also for our clients. And that we may have to alter a little bit when dissociation is present with our clients to make it a focus, which many of you are already doing, but maybe it needs to be even more of a focus as we assess their current surroundings in therapy. Now it's time for some questions and answer. And Michelle, if you could help lead us through that.
Thank you, Dr. Wetterneck. We have many questions and we'll get through as many as possible. I know many of you are asking if they could get a list of the tools that Dr. Wetterneck and Kramer spoke about, and also these PowerPoint slides. So just to let everyone know, it will be available on the Rogers website after the webinar. The first question is, how do you feel about beginning sessions by teletherapy if you have never met the patient in person?
Yeah, I mean, I think one thing I would say is I would just be open and honest about that being another variable that comes into play. Just like sometimes when I meet with a female who I know her abuse history was primarily from a male, I acknowledge that pretty early on that this could be a challenge. And so, if, you know, I want to be aware of their comfort level. And the same thing with talking online.
Thank you. The next question is, what would some of the alternatives to medication be for those who were stabilized on medication?
Sure. And, you know, there are, again, certain medications that we're noticing more of a shortage, but luckily, the vast majority of psychotropics are not going to be affected by the COVID crisis, at least not currently. So, you know, your serotonin medications that have an FDA indication for treating PTSD, as well as the spectrum of the anxiety disorders, as well as major depression. So even if there is a medication that's in shortage, you can always go with another option in that same class. So for now, I feel that that can be a concern, especially for medications such as fluvoxamine XR. It's for OCD and social anxiety. We are noticing that there's a shortage there, but I would recommend, if you do have a client who is struggling, just to reach out and talk with their provider so that they can go over options and so that that client can make an informed decision as to what alternatives they'd like to take. And then I can let Dr. Wetterneck talk about the flip side of the coin, because I always let my clients know that while medications can help, you know, it's really the psychotherapy piece where you're really going to notice a difference. So pharmacotherapy and psychotherapy can work synergistically, but the real focus for trauma work is invariably on that psychotherapy piece.
And so very few of my suggestions will have the same effect as a PRN or something like a benzodiazepine. And at the same time, we want to be able to teach not only grounding techniques to our clients, but also ways that they can teach themselves to lower their baseline level of autonomic arousal and anxiety. So we do things like diaphragmatic breathing. We do things like progressive muscle relaxation. We encourage things, whether it's outpatient clients or in our own programs, to do things like yoga and get inside of their body, you know, choose your words carefully here, but so that they can understand that they do have some control over how they feel, not only emotionally, but also physically, and that they can achieve some, I don't want to say they'll achieve complete relaxation, but they can lower their baseline, and it does make them feel like they're more in control.
Thank you. The next question is, Can EMDR be effective and be used online? We had a few questions for that.
So I think, like anything that hasn't been studied enough in this particular modality, we have to kind of look to the data and say, do we know for sure that this can work? So I don't want to tell you that anything is foolproof. And I also think that what I know about EMDR is I do believe you should be able to administer most of the components of EMDR at I guess I would say above a 90% level of efficiency in the A range. And that I would anticipate that as long as the things that you're asking them to do visually or things that you ask them to have on hand, whether they be sensory or otherwise, are present in terms of some of the grounding skills, that you should be able to implement it and have it be effective. I just want to make sure that I'm not saying that because I think there's 3 dozen studies on it and it said that. I just recognized it as something that has a lot of empirical support.
Thank you. The next question is, now that I am practicing remotely, I find that I am more emotionally exhausted from my therapy sessions. Is there research suggesting that providing care via telehealth increases provider fatigue and burnout?
It's a really good question. And I wish I could tell you that I for sure know that there's research that could be cited on it. I do know that I've read that more anecdotally, and there might be research on it, but that seems to be a pretty constant phenomena. And that's something that I said about like the new job phenomena on that slide that I talked about, where you could be doing the same job, but the fact that you are not used to it, you are using for anything that isn't a part of your rote behavior. So some of you can go through your sessions, even though you're listening very in-depthly to what your client is saying, connecting with them, you just almost on autopilot know what to say and how to react and how to connect to them and where to go next. And there's something about, now I have the screen in front of me, now I have my mask on, and it feels as though you've altered the whole treatment environment, and you have to think about things, and you're probably using more of your executive functioning than you are some of your more rote behavioral processes in your brain. It's literally making you think harder.
Thank you. The next question says, it seems that some clients find it easier to suppress or dull their emotions when completing imaginal exposure via telehealth versus in person. What suggestions do you have for a greater emotional engagement if you notice this is occurring?
I think the first thing I do is I'd want to normalize that as a possible response. I would want to understand a little bit more, especially if this is someone that you worked with and all of your, whether it's an imaginal exposure or whether you were doing processing with EMDR, if all of your work with them was through tele, I would normalize that and have them understand what might be different about what you did in a room with someone versus tele. And some of that is, I do feel as though there's this interpersonal dynamic that we develop when you're in a room with someone. They're gonna have to look you directly in the eyes. And even if you're on tele with them, they might not have that same level of heightened awareness of someone else in the room and observing their trauma happen. So I normalize that as part of the response. And then I'm gonna go back to some of the same techniques I would do if they were in person with me. And I'm gonna coach them through, if you can get multiple trials of them talking about their imaginal exposure, I'm gonna ask them to potentially slow down during the times which they report the higher levels of anxiety. And ask them to talk a little bit about and use more anxiety words, but they don't have to narrate that whole part. I want them to sit in that feeling a little bit more. And I might prompt them and coach them that I'm going to prompt them, can you just stay with that a little longer without talking, because I don't want them to go to their prefrontal cortex and think about it. I want them to be more in the feeling part of their brains.
Thank you. We have time for one more question. The question is, do you have any suggestions for in vivo exposures for hypervigilant or crowd avoidant patients that remain safe and appropriate during the COVID-19 pandemic?
Yeah, that's a really good question. And I bet there's there might be about 100 variables to consider. So let me think of a couple things, and Dr. Kramer, if you have any, let me know. You know, one thing is if they're gonna go out and they're gonna wear a mask, I think the first thing you have to start considering is whether it affects, whether part of their trauma had to do with their mouth being covered or told to be quiet, or even whether they have panic symptoms or not. I want them to try on that mask and wear it for part of my session. And I want to get an accurate rating of what is your anxiety or discomfort while you're wearing the mask? Because I'd likely want to design some exposures around the fact that they're going to have to wear a mask. And then I want to remind folks too that do exposure work in general. There's a couple of different philosophies in exposure work. In OCD work, we often talk about, many of you probably watched those seminars, we talk about overcorrection. You have people do past what you would want them to do. You know, if they're going to get contaminated, you're going to have them touch their hands to a toilet seat in public. Nobody does that unless they're doing an exposure. We don't have our trauma patients do that though. We ask them to do things that would lead to them having a meaningful life. So we'll ask them to still engage in social distancing practices and wear masks, but we need to know, will they be even more hypervigilant in a grocery store trying to order stuff with a mask on and feeling a little panicky and trying to maintain social distancing and trying to be hypervigilant? So we may have to break that down into more safe exposures that they do either in session with us, or maybe if they have safe people in their house that they're having people practice standing by them or behind them as if they're in a public setting.
And absolutely, and I'd like to add, it's not just about the client wearing the mask, it is what is going on universally. Everyone else is wearing masks. So you know, that can also be very triggering because you can't see their full face. And you know, a lot of our patients read intentions, and so they see something as a threat based on observation, and a mask can be seen as a threat. So that also would need to be incorporated, maybe having opportunities to go to places that they would otherwise consider to be safe, and then work up to places that are more crowded and that may have more of a potential risk per se for the client.
Thank you so much. And I would also like to mention that you had many comments thanking you for this useful information. It's been very helpful for our participants. Thank you again, Drs. Kramer and Wetterneck, for taking the time away from your clinical practice, as well as sharing your valuable insights with us. I'd also like to let you all know that Rogers is here for those who are struggling with mental health or addiction, now potentially more than ever. We are continuing to accept patients in both inpatient and residential settings in Wisconsin. And we are very proud to offer Rogers Connect Care, a virtual option for those needing intensive outpatient levels of care. Drs. Kramer and Wetterneck, before we conclude, please share your recommendations on additional resources for our participants.
So the CDC has a wealth of information, including a list of medication shortages, but also updated information that you can get on a regular basis in regard to restrictions for COVID-19. The American Psychiatric Association, again, is an excellent resource. So I would consider APA as a resource if you're looking for some evidence-based medicine articles. They're usually very timely and up-to-date.
And I'll just add that the Department of Defense, we also have listed here, they do a fantastic job of trying to normalize and have people either role play or actual patients like talk about their experiences in the VA system. And I realize that might seem really specific, but so many of what things that they do, whether it's the materials or the videos, they actually apply to a wide range of people that have experienced trauma. So please check that out.
Thank you. That about wraps it up, everyone. I want to remind our participant that those of you who met the required time commitment will be eligible for CE credits. You will receive an email with a link to a mandatory evaluation form. Once you complete it, you may download your CE certificate for the event. We will have a recording of today's webinar and the slides available on the website rogersbh.org. There were some questions about assessment tools, and we will include that as well. I hope you'll join us next week, Thursday, May 21st, for the final webinar of the series, Treating Trauma During COVID-19. Doctors Josh Nadeau and Lauren Post will focus on the differences in treatment approach for PTSD between in-person and telehealth delivery, address assessment and treatment concerns related to symptom changes associated with environmental stressors, including COVID-19, and consider the impact on treatment as quarantine and stay-at-home orders are relaxed. On behalf of everyone at Rogers, we look forward to partnering with you and helping you to support your patients. Thank you.